Welcome to Introduction to Healthcare and Public Health in the U.S. Meaningful Use. This is Lecture C. This component, Introduction to Healthcare and Public Health in the U.S., is a survey of how healthcare and public health are organized and how services are delivered in the U.S. It covers public policy, relevant organizations and their interrelationships, professional roles, legal and regulatory issues, and payment systems. It also addresses health reform initiatives in the U.S. The objectives for this unit, Meaningful Use, are to define meaningful use, or MU, of health information technology in the context of the Health Information Technology for Economic and Clinical Health, or HITECH Act. Describe the major goals of meaningful use. Discuss the criteria for stages 1 to 3 of meaningful use for eligible professionals and eligible hospitals. Describe the standards specified for MU, and discuss the likely evolution of the MU program. In this lecture, we turn our attention to clinical quality measures, or CQMs. Remember that there were clinical quality measures specified in 2011 when the Meaningful Use program started, and then new measures that came in 2014 that were required of all Meaningful Use program participants, no matter what stage they were in. In the original CQMs, eligible professionals, or EPs, had to report on 3 core measures. For some EPs, those core measures were inappropriate. For example, they might have a denominator of 0. Therefore, some substitute measures were allowed. There was also a list of 38 additional measures, of which 3 need to be reported on. Eligible hospitals, or EHs, had to report on 15 measures. This slide shows the core CQMs for eligible professionals. Recall that there were 3 core and 3 alternatives that could be used if the core measures could not be measured. The core measures included blood pressure measurement, tobacco use screening and cessation intervention, and adult weight screening and follow-up. The alternatives were weight assessment and counseling for children and adolescents, influenza immunization, and childhood immunization status. There were also an additional 38 measures for eligible professionals that are not listed here, of which 3 needed to be measured. This slide and the next 2 slides show the CQMs for eligible hospitals in the 2011 Meaningful Use rules. Each hospital needed to report on all 15 of these measures to achieve meaningful use. Starting in 2014, the measurement of CQMs was expanded. No matter which stage of meaningful use one was in, eligible professionals and eligible hospitals were required to move to the 2014 CQMs. For eligible professionals, that required the use of 9 out of 64 measures, with at least 1 measure coming from each of 3 National Quality Strategy, or NQS, domains, which are shown on the next slide. Eligible hospitals and critical access hospitals now needed to complete 16 of the 29 measures, with at least 1 measure being in each of the 3 NQS domains. The National Quality Strategy, or NQS, domains are patient and family engagement, patient safety, care coordination, population and health, efficient use of healthcare resources, clinical processes, effectiveness. Within these domains, there are different quality measures that must be used based on the rules described on the previous slide. In the next few slides, we will look at the number of registrations and payments made through the Meaningful Use program. This data is released monthly by the Centers for Medicare and Medicaid Services, or CMS, and then periodically summarized. What we will look at here is the data through the end of 2015. As we can see, there have been over 362,000 Medicare-eligible professionals registered, 191,000 Medicaid-eligible professionals, and nearly 5,000 eligible hospitals. This table shows the number of providers who were actually paid for meaningful use through 2015. The data show there was a large uptick in the early years and then somewhat of a saturation with fewer new unique providers joining the program. But in total, there have been over 300,000 Medicare-eligible professionals, over 156,000 Medicaid-eligible professionals, and almost 4,900 eligible hospitals paid for achieving meaningful use. This table shows the dollar amounts that have been paid out each year. Of note is that the program has ended up costing over $31 billion, which is somewhat more than was expected. We can also see that the payments have tapered off as fewer EPs and EHs have achieved Stage 2 of meaningful use. How successful has the Meaningful Use program been? In terms of spurring the adoption of electronic health records, or EHRs, it has been quite successful. Whether office-based physicians, emergency departments, outpatient departments, or hospitals, the proportion of those using electronic health records has increased substantially since the beginning of the program. Probably the most successful measure has been in hospitals, with 96.9% of all U.S. hospitals now having an electronic health record, even if they have not achieved meaningful use with it. That is, in essence, near universal adoption of EHRs in hospitals. However, there have also been challenges for meaningful use. Some categories of hospitals have had more challenges than others. In particular, critical access hospitals, smaller hospitals, and public hospitals have had more difficulty meeting meaningful use requirements, as have pediatric hospitals. Many EPs and EHs have noted the challenging criteria, which some describe as unruly workflows. These criteria are things such as having to provide clinical summaries to patients, electronic prescribing, reporting clinical quality measures, recording vital signs, and recording smoking status. It has also been noted that some of the critical functions in the practice of pediatrics are underrepresented in the meaningful use criteria. It has also been shown that compared with manual chart review, the more automated clinical quality measure reporting had some variations in its accuracy. Finally, in general, achieving Stage 2 has been challenging, even for hospitals that already had electronic health records. What about the effect of meaningful use on patient care? There have been both positive and negative studies. In terms of positive studies, one showed that rates of adverse drug events were lower in eligible hospitals that had adopted the core medication meaningful use criteria. Another study found that hospitals with higher EHR adoption had improved performance on process quality measures and higher patient satisfaction, although no demonstrable improvement in efficiency occurred. On the negative side, other studies have shown that primary care physicians tended to score better than specialists when it came to meaningful use, although 90% of those primary care physicians had one or more exclusions. Another study found that physicians who had achieved meaningful use were not any better in providing higher quality care than those not achieving meaningful use. What about the future of high-tech and meaningful use? With the difficulties of achieving Stage 2 and the worries over the requirements for Stage 3, there has been growing pushback. In particular, there has been criticism of the functional use objectives, such as the requirement that one have 80% of patients with problem lists or 60% usage of computerized physician order entry, or CPOE. Many have argued that these functional use objectives are stifling innovation and flexibility of vendors and are not giving sufficient attention to interoperability, which many considered to be the most important aspect of EHR use. In 2015, 36 medical societies wrote a letter to the Secretary of Health and Human Services expressing these sentiments. And in 2016, 31 provider organizations wrote a similar letter. Others have also written of shortcomings of the Meaningful Use program and how it can be modified going forward. Robert Wachter has stated, "Perhaps it's just time to declare victory and move on." Even the leaders of CMS and the Office of the National Coordinator, or ONC, have been responding to these criticisms, and in fact, in early 2016, the head of CMS stated that with the Medicare Access and Chip Authorization Act, or MACRA, there would be changes in meaningful use. although meaningful use won't go away because it's enshrined in legislation. This concludes Lecture C of the Unit on Meaningful Use. In this lecture, we reviewed clinical quality measures that are used as the standard for meaningful use. We discussed which CQMs were used prior to and after 2011, what core and alternative CQMs applied to both eligible providers and eligible hospitals, and the stages of change to CQMs that started in 2014. We went over the National Quality Strategy domains and their related quality measures. We looked at the number of registrations and payments made through the Meaningful Use program. We examined the challenges for meaningful use, as well as its effect on patient care, both positive and negative. Finally, we briefly touched on the future of the HITECH Act and meaningful use. This also concludes the unit titled Meaningful Use. In summarizing this unit, the goal of the HITECH Act is to provide incentive for the adoption of EHRs by eligible physicians and hospitals. Eligibility for HITECH Act incentives is provided by meeting the criteria for meaningful use in 3 stages. Meaningful use also requires the reporting of quality measures. And the HITECH Act has provided over $31 billion in incentives and substantially increased the adoption of EHRs in the U.S.